Thank you for joining us for Season 5, Episode 21 of Doc Talks with Dr. Forrest Tennant and friends. We have an enormously, extraordinarily exciting time ahead of us. Dr. Tennant has some great things he wants to teach us, and then we have some surprises afterwards. Thank you, Doc. It's all yours.
Okay, thank you very much, Jamie. Tonight is an exciting tonight. I'm going to give what I think is an extraordinary educational message, one that I can't be more excited about, and it'll be new to you. And then most of the program is going to be turned over to Pat Irwin, who's going to talk about our new Medical Board Awareness and Advocacy Initiative, which is going to be very educational for both patients, families, doctors, and medical boards. I think you'll find that to be the case when we get into it later today. But I want to talk about something today that to me is probably the most exciting thing that I've talked about. It may not sound very exciting to you, but it is to me because it's sort of a lifetime professional dream. And that is a simple word called neuroregeneration. Now, what am I talking about here? You've heard for a long time, those of you who have seen this show or read anything that we publish at Arachnoiditis Hope or in Pain News Network, you know that we are great champions for trying to find a way to permanently reduce pain. In other words, you've got symptomatic pain treatment that we all have to have. That gives you pain treatment for 4 hours, 6 hours, maybe 12 hours if you're lucky. But then we have a concept of permanent reduction of pain. Now, people who have what I call constant intractable pain know exactly what I'm talking about. They know that they've got a background of pain that's always there, 24/7. It's always, you can number it if you want. It can be a 5 in your case, or a 7, or a 10, or a 15. It doesn't make a lot of difference. It's your baseline pain. Now, you've heard me talk about to treat this condition, you've got to do 3 components of a medical protocol. Number 1, you're going to have to probably reduce or suppress inflammation and autoimmunity. Secondly, you've got to have control of pain. But thirdly, you've got to try to regenerate damaged tissue, and particularly nerve tissue, meaning nerves, arachnoid membrane, glial cells, components of the nervous system. I want to introduce the term neuroregeneration, is what I'm talking about here now. Neuroregeneration means to regrow a damaged nerve. That's what it means, or nerve tissue. All right. Now, what's important about this concept is simple. People who have constant intractable pain will have 2 kinds of damages. They'll have a damage maybe in their lower spinal cord, like with arachnoiditis, or out on their leg with RSD, or in their joints with arthritis, or with their small nerve fibers in the groin, something like that. Okay. Now, in order to permanently reduce pain, okay, one has to have neuroregeneration. There is no option. In other words, we have to regenerate damaged nerve tissue, okay? And for those people who have severe intractable pain, and for most of the people who watch this show, you will have damage both in what we call a peripheral nerve, as well as in the central nervous system. Now, let me explain what I mean by that. Okay, if you have RSD of your leg, you know what I'm talking about. If you have arthritis of a joint, you know what I'm talking about. If you have pudendal neuropathy in the groin, you know what I'm talking about. If you have arachnoiditis, you have damage in your arachnoid membrane and in your cauda equina. So you know where there is damage in those locations. But you have a second place that you have damage, and that is in the central nervous system and in something called the glial cell network. And these are comprised of small cells in the brain that really control pain. Now, when people develop an inflammatory condition or an autoimmune condition, these cells get damaged either by autoimmunity or excess bioelectricity, but they get damaged. And so constant pain is when these glial cells are deranged or damaged. Okay, now to reduce your pain permanently, those cells have got to be regenerated and start working. They've got to start conducting electricity. So the bottom line, and the prayer of us people who have tried to deal with treating pain, we want neuroregeneration. We've got to have that to give people permanent relief. Now the question is, how do you do it? Well, we've known for some time that certain types of exercise, certain diets, and things give us some perhaps neuroregeneration. But the big breakthrough came a few years ago, and I'm going to talk to you about some research that you're probably not familiar with, but it's potent research. In my way of thinking, it's in the top 2 or 3 major bits of research in the last 20 years that involves intractable pain. And that is, it has been discovered that the spinal cord itself makes a set of hormones called neurosteroids. Okay, now they're called steroids because they have the same chemical structure as cortisone, but they're a different breed. And you know most of these hormones. They actually are known to the public by name. They go by the names pregnenolone, dehydroepiandrosterone, that's DHEA. You're also familiar with allopregnenolone, and there's progesterone and plain estrogen and testosterone. Now, all of you are familiar with what estrogen and testosterone does to the body and the sex organs and life. But what you don't know is that the good Lord intended this class of compounds to be healers of the central nervous system. They are neuroregeneration compounds. And if you are to get better, get your pain reduced from a permanent level of, say, 8 or 9 to a 3 or 4, those hormones have to be in action. Now, let me tell you about some unbelievable research. This may sound a little gross in a way, but it's the way research is done. Researchers took rats and they severed their spinal cord, and then they administered to them pregnenolone or progesterone or DHEA, and saw that the rat's spinal cord would reanastomose, so the rat would quit walking around the cage and start walking again. Now keep that in mind. These are what neurosteroids have been shown to do. So I and a handful of people have been trying to give these hormones for some time, and they were working a little bit, but not like we wanted them to. Okay? So we've been trying to get, if you followed any of my work, you'll know I've been trying to get people to use medroxyprogesterone or DHEA or pregnenolone for a long time. And I feel we've had some successes, but the successes were not what we wanted. And then something else came along, and you can thank this show to some extent, and that is some bright entrepreneurs in this country, thanks to the capitalistic system, started making synthetic peptides. And we've talked a lot about on this show. And you've had a lot of testimony here about how peptides seem to work pretty well. Now, here is the news I'm bringing to you tonight. It has come to pass that a number of people with severe constant intractable pain, particularly adhesive arachnoiditis, have started taking a combination of the neurosteroids and the peptides. And guess what? They're getting results. As a matter of fact, they're getting results that are amazing to me, that are the most welcome thing that I've seen in this business for quite some time. Let me say it again. These people are clearly, by using a combination of neurosteroids and peptides at the same time, are getting some permanent neuroregeneration and permanent reduction of pain. And these reports are coming into my office weekly, okay? And we've got some people who've gone from 8s to 2s. Some people are now out of bed and walking. In other words, now, and I'm here to tell you, it is my futuristic statement, I'll say it very plainly. I believe that the combination of peptides and neurosteroids are the wave of the future. And that if you're stuck in this business of constant intractable pain, you need to start exploring very quickly how you use a combination of neurosteroids and peptides. And frankly, it's simple to do, very simple to do. It might shock you how simple it is to take this combination. Now, let's talk for a couple of minutes about the popular peptides and about the popular hormones, okay? The popular hormones, pregnenolone, DHEA, colostrum, medroxyprogesterone, and then there's old-fashioned estrogen and testosterone. Okay? Now, you need a list of those because you need to be taking one of them. Now, the popular peptides today, the most popular peptide is something called body protection compound, better known as BPC 157. KPV, that's one that we almost introduced on this show. That's lysine, proline, valine, and it's usually called KPV. Another one that's being used today, AR290, that is specifically designed for neuroregeneration. And lastly, thymosin. Okay, it's both an anti-immune, auto-inflammatory, but it's also builds tissue. So, what everybody needs to be thinking about right now, if you've got constant intractable pain, I want you to be thinking about, could I be taking a combination of these specific neurosteroid hormones and peptides? For example, you can get a bottle of BPC 157. You can get a bottle of DHEA or pregnenolone down at the local health food store, 2 of each a day, and you're in. In other words, you don't have to, you can take injectable peptides, you can take it by nasal, you can take it in a very potent form, but these things come orally. You can purchase them even without a doctor's prescription. And so I'm now advocating that if you have one of these conditions like adhesive arachnoiditis, RSD, small fiber neuropathy, pudendal neuropathy, you need to be looking into what I now believe is the very best and maybe the pinnacle, if you will. And it's just kind of a scientific breakthrough, the combination of peptides and these hormones. Think of it this way: the peptides enter your tissue to grow it. Your hormones are your energizer. It makes the peptide work. It makes the combination generate, and it works both in the central nervous system with the glial cells, as well as maybe in your cauda equina or in your pudendal nerves. So again, I will close off this concept. Neuroregeneration must take place for you to permanently reduce severe chronic pain. And I'm also now here to say is that we have a new scientific, what I think is a breakthrough, and that is the combination of these neurosteroids and peptides used together seem to be our very best hope of trying to regenerate permanently damaged nerves both in the brain and in the peripheral nervous system. With that, I'll sign off, and I hope you'll hear more about this in the future. I now want to turn this show over to Pat Irwin and to Jamie to carry on the rest of the program. Pat Irwin is doing a wonderful job in getting us organized. Let me just say this about our new medical board awareness program. Each state has a medical board, and a lot of people don't really know what they do, but they not just regulate doctors, but they set a medical tone in every state as to what's acceptable, what's not acceptable. These medical boards are political appointees, and most of them are dedicated public servants. They want to help, they want to serve, but they're lay people. They're political lay people for the most part, and they wouldn't have any idea about what neuroregeneration is or about central pain or descending pain. They know nothing about this. And up until now, no one's really tried to do any education of them or work with them. But we've got some people associated with this show who have had great successes in working with medical boards and found out they really are comprised of a lot of decent people who are here to help, but we can help them and they can help us.
Well, welcome back to the second session of our advocacy series. And again, this is thanks to both Dr. Tennant and to Red Lawhern for their leadership in putting this alliance together and really opening the door for us to have this amazing initiative. If you missed session one, it is session number 19, and all the information is on Doc Talks. How to get a hold of that link. I'll also make sure that it goes along with this YouTube session so that you can find it. We launched our first goal at the last meeting, and that goal, I think most of you know, was just for people to begin to look for their medical board, even find the website. And once you find the website, to see what kind of guidelines that they have. And I know that that was a big ask for the first step out of the gate. And I know that a lot of you tried. I even had one person say that she did it with help, and that is glorious. I hope all of you felt comfortable asking for help with these action goals. If you ever need help, just ask. There's a lot of us who are more than happy to help. So we will be talking more about that. What I'd like you to do next is I would like to get some feedback on what you found when you did your search. So if you can type into chat, each one of you, a yes if you found guidelines. So first of all, I'm sorry, your initials, your state, a yes if you found guidelines, and a no if you didn't find guidelines. In terms of sharing the information that I've gotten to date with who is signed up for which state, and again, signing up doesn't mean you're going to do a ton of work, it just means you're participating. I will put this grid up on the Doc Talks website, on the Facebook forum, sorry, so that you can see who else has signed up for your state. And next session, it's a little early, next session we'll talk about how do you work with your group? How do you find the other people? How do you work with the other people? We're a little early for that, but just know we're kind of grouped. There's 7 people for Alabama. There's like 7 people in California. And so we don't want you to run into each other. We want to be able to be synergized as a group. So we'll talk about that next week. In the meantime, let's go back to the guidelines that you are hopefully found. It's important to realize that not all guidelines are made the same, obviously. Some are going to be much better than others. There's going to be some commonality, but first off, just from the start, you're going to find they're called different things. Some of them might not be called guidelines, they might be called rules. Maria knows about that, or they might be called strategies. So don't get too worried if what you found didn't have the name guidelines on them. Most critically, they're going to vary in how well they support legitimate pain control. And I'm going to talk today in detail about how do you assess your guidelines to know whether they're supporting us or not supporting us, right? Dr. Tennant mentioned, what's the tone? Many boards, the tone is positive. They want to support us. Many boards, that's obviously not the case. So you're going to assess the guidelines to know, okay, is this something we can work with? Do we need to change? Can we leave it the same? Where are we? Thanks to Maria Higginbotham, she found the most amazing set of guidelines to look at, to kind of evaluate your guidelines. And to evaluate the guidelines, there's a couple of ways. You want to look at are controlled substances, pain meds and benzodiazepines, are those seen as necessary elements to pain control? Right? Or is it clear that they don't want you to use controlled substances? Are practitioners' concerns about regulatory scrutiny addressed? Have they, for example, said in the guidelines, we know this might be difficult for the provider, for the physician, and this is what we're doing to support them? Are patient treatment plans individualized? Do they have some blanket protocol that deals with every single patient in Northern California? Or are they individualized so that the physician can treat each patient and as an individual? Are there dosage limits? There should not be, at this stage in the game, dosage limits. It's a question. Is physical dependence confused with addiction? Are they in the guidelines saying patients are going to get hooked on their pain meds, right? Be careful, watch out, danger, danger, right? You can tell that right away in the guidelines. Is the wording supporting the false narrative? What the heck do I mean by that? So the false narrative is what Prop has been putting out there for years. The false narrative is opioids are highly addictive, there's diversion, they lead to overdose. That's the false narrative. So if you see that language in the guidelines, the red flag should go out that these guidelines need work, and they're going to need a lot of work. Is OUD a frequent outcome? That's the other one they like to throw out there. Another element you want to look for, are patients encouraged to be involved in the risk-benefit discussion? And do they foster shared decision-making? Last but not least, is tapering addressed in a scientific and humane way? So is tapering encouraged? If it is encouraged, what are the parameters that they put by? Do they allow the patient to pause if they're in a taper? Right? Very, 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 very important. So you should look for how do they address tapering. So consider those factors. Once you've found your guidelines, then you want to look to see, how are my guidelines doing? Assess them using those criteria that we just put down. That's what I'd like to do. We talked about evaluating the guidelines. I'd like to give you some great information on 3 states where there's already been progress made, so you can see how far we've already come. We've got a long way to go, but let me tell you some successes we've already had. There's a little bit upbeat here. I don't know if Patrick O'Donnell is on. I can't see him. Kitty cat, you got to get down. But if Patrick's on, he has done an amazing amount of work with the Alabama board. And he is eager to get together. I think there's 6 or 7 of you in Alabama. He's eager to get together with you and work with you as a group. He and Red gave a presentation to the Alabama board. I think it was January, it might have been February. And this presentation that they gave them was focused on the false narrative. So what they did with their board is they went through and they told them, these are how the false narrative is incorrect. Opioids don't foster overdose. They don't lead to massive amounts of OUD. They don't lead to massive amounts of diversion. So this PowerPoint that they used is available for use if you get to that stage with your board. So know there's a PowerPoint out there that Red developed, and Patrick has already presented to the Alabama board. Patrick's also accountable for putting together the Reddit site that we have, which is for all pain patients to use. And I put the link right there on the slide. So please feel free. Everyone is welcome on that Reddit site. We want lots and lots of people to sign up and use it as much as you possibly can. Let me next go to California. We have a group of 6 or 7 of you in California, and this is wonderful news as well. There's been a ton of work done in California, but we are far from done. Let me give you a little background. Monty Goddard and Kristen Ogden, who you both know, began working with the board long before I started. And in earnest, I would think it was in 2022, they can correct me if I'm wrong, where the board agreed to have an opioid task force to look in detail with their guidelines. They had guidelines in 2014 that were drastically outdated and not very patient-friendly, that needed updating. And so both Monty and Kristen participated in this work that went on for well over a year with lots of participation from experts from Stanford, et cetera. And they ended up with guidelines that were approved in July of 2023. And they're not perfect, but they are very, very close. They talk about pausing in the tapering. They're great guidelines. So they might be good if you don't have guidelines in your state. the California guidelines are certainly something you could look at. Next, I want to talk about Washington State. I know Maria's here tonight, and I want to call out Maria for the tremendous work she has done with the Washington State Board. She's been working with them, again, well over a year. The board is called the Washington Medical Commission. See, all these names are different. And they don't have guidelines. They have something called rules, but they do the same thing. They talk about how the prescribing should be done. They guide the physician in that process. She was able, with her team, to get Washington State to agree to relook at the guidelines, that the rules that they have right now, and to update them. And right now, as we speak, thanks to Maria, they are reviewing their rules. And we can help Maria by going to their website. I put the link up there, and letting Washington State know that, yes, what you're undertaking is important. It's supported by science. We, as an alliance, support you. And you don't have to be from Washington State to do this. So please, 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 finding their website and going to the place that you actually enter your comments is a little tricky. I think I've got it right on here. Maria, later, if this is not right, you can help me out. But do try to give Washington State comments, because they're right in the rulemaking position. What is in common with these three states? In all these states, the people involved made a relationship with their board members. That's what is in common with all of them. They took the time to get to know the people on the board, to get to know how the board functions, and they've got on a first name basis. It's relationship building. So when I go later and talk about strategies, you can go through the steps, but it's really, you want to just keep asking yourself, how do I get to know these people that are making these important decisions? How am I going to influence these people for better or for worse? In addition to state guidelines, I very quickly want to let you know about broader guidelines that are out there, just so you'll have an idea. And there's two in particular that you should know about. A lot of you may already know about the Federation of State Medical Boards. And this is a national non-for-profit organization that doesn't have regulatory power over the states, but they act as the voice and the resources for all the state medical boards. So in a way, they do speak for the states, even though it's not in a regulatory capacity. And they just updated their guidelines, which I think are actually called strategies, in 2024, so last year. And if you were to use the criteria, the good, the bad, and the ugly, you would find these guidelines are so-so. It was very disappointing when they came out, to be honest. There's multiple references to the CDC guidelines. There's multiple references to the false narrative in a bad way. I put an example there. They say opioids can contain considerable risk, right? And then don't really explain the rest of it. However, there's some good in it. They have a good passage on tapering that does talk about pausing for the patient. And there is some good support for shared decision making. Overall, I would say these are not the best guidelines to use as an example. So if you're working with a new state and you want to get them educated, honestly, and it's not because I'm biased, it is criteria. I would use the California guidelines before I use the FSMB guidelines. They're just do not give us the support that we really need. It was a step in the right direction, but they did not come far enough. The other guideline that you should know about is what the World Health Organization just put out. It's important to know that these are not guidelines in the true sense that we talk about guidelines, which would be something that would target the physician to what they should be doing, what is best practice. That's probably a better word. What is best practice, evidence-based, science-based for the patient? What they really are policy statements that WHO has put out to say, we think in our mind, and I've listed them, access to opioids is a human right. Regulatory barriers should be removed. The prescription management programs should not be used to punish practitioners. Patients need to be included in policy development. So they may make statements, and it's a policy statement that nations can use to build their own guidelines. I realize that there's a lot of politics right now behind WHO, and I don't want to go into it. It's not important. What's important is these policy statements are available to you, and you can use them as you think your state will accept them. If you have a state that is dug in their heels and does not want anything to do with WHO, then it's going to be a big fight. You need to think about using them. If you have a state that's more neutral or is open to WHO, then by all means, you should mention that these policy statements exist and that they'd be beneficial for them to look at. I do want to mention one last fine point on this. As far as I know, I checked this morning, the actual true guidelines have not been released yet. What has been released is a pre-release memo, which goes into a lot of detail. You can get fooled in thinking, this is the final product. But as far as I know, the final product's not out there. It's supposed to be released by the end of this month. So we're waiting for the final. In the meantime, the statements we've seen from them are very encouraging. And politics aside, what have they said that we cannot agree with? I mean, it is just very, very positive. Once you've assessed your board, you are going to want to plan for how you're going to approach them and influence them. That's our whole job, is to influence the board. You're going to start, and our next assignment is going to be listening into your board meetings. You can watch it live. Most boards record their meetings, which is great, because then you can listen, and if they start talking about something absolutely off target, you can fast forward ahead and get to things that maybe are more pertinent. It's very important that you find out how your board works. In the case of the California board, you actually have to sign up if you're going to go live before the actual webinar happens. So little things like that. How does your board work? How do you get signed up? Can you get signed up for the agenda and the meeting and the minutes ahead of time? Looking at the agenda, of course, will be a godsend in finding out, is this a good time for me to intervene? What can I intervene on? How do I want to strategize my plan? We talked about assessing the board's openness to listening to us, which is kind of part of the overall plan. You want to locate their contact email and a contact person. Kristen and I were talking earlier today, and she was saying it's so helpful to have somebody on the other end of that phone, not a board member necessarily, but the person who answers the phone or directs the call or sets up the meetings. There's always usually a person who is responsible for setting up the meetings. That person is just a gold mine. And so if you can make contact with them and get to know them better, that's a great in. Once you've done all that background work, we've talked about this, and you want to design a plan for intervening with the board. And that's a future topic. We'll go into the details of the plan for intervening. This slide is extremely important. We just talked about the how. How do you work with your board? How do you get to know them? But now what I want to talk about is, well, besides looking at the guidelines, what are we going to communicate to the board? What is it that we want to say? What are we as a group of pain patients trying to get out? Dr. Tennant came up with this list. I took the liberty, Dr. Tennant, to kind of mold it around a little bit to be grouped together by root cause. I hope that's okay. And then Red had some good points that he added as well. So this is Dr. Tennant and Red looking at what it is, what's our grievances? What are the things that we want to say to the board? And they're pretty obvious. They're pretty obvious. Physician and insurers, patients are forced tapered. End of life and palliative care patients are unable to get the care that they deserve. The practitioners are unwilling to prescribe enough or at all. And co-prescribing is a nightmare. Good luck with that. And practitioners have no set definitions for really, the law talks about legitimate pain patients. DEA talks about legitimate pain patients. What is that legitimate pain patients? We don't have that definition, and so we all struggle. And patients are forced to have interventional procedures to assess medications. These are all grievances, topics that are absolutely in the ballpark of what your state medical board should be doing. Their job is to protect the patients in their state. And this is, all of these asks are something that they need to hear if they have not heard it before. This is something they should be doing. The next group of grievances, I separated out. The medical board cares, but the pharmacy boards are going to care more. And I know right now we're focused on the medical boards, but we will be talking more and more about pharmacy boards as time goes on. So just know, here's a list that has to do with getting your medications. The pharmacies are closing. They're running out because of quotas or thresholds. You can't get the medications you want. And pharmacists are, we know better than anyone, they're erring on the side of what they think is safety or their fear. And so even if your doctor orders it, the pharmacist isn't going to dispense it. These are all things that are important grievances that we need to talk about. And last, physicians themselves are being persecuted. And it's not just by the DEA. They're being persecuted by their own hospitals, their own, and by their own state boards. In many cases, the boards, their disciplinary side of the board has not come around. Their culture has not changed. They are still in the mode of, oh my gosh, this physician prescribed over 50 MMEs, 90 MMEs, whatever ridiculous line in the sand they have. And the board is the one that's not being helpful. The board themselves are oftentimes, when these cases go up through the chain, are being hard on the physician. So there's more than one reason that we need to work with the boards. It's sometimes the boards that are causing the most problem, which is very unfortunate. One critical note, I mentioned, it's true that we are not focused on pharmacies right now, but there is one topic that we cannot ignore, and I had to put it in here. It's become so detrimental to patients, and that is the shortages. And the causes are both the DEA quotas and something I hope you've heard about, but you may not have, and that is the thresholds that come with the injunction. This is a whole 40 minutes top discussion on its own, what the injunction does and what the thresholds are. But suffice it to say, just really quickly, thresholds are limits that's put on the pharmacy that after they've gone out over that amount, their supply of controlled substances stop, and they get reported to the DEA, to their state AG. It's just absolutely horrendous. So what people don't know, and this is the part I want to get across, if you remember nothing from my talk tonight, there is a legitimate way for the pharmacist to ask for an increase in their threshold. It's actually written into the injunction. State pharmacy boards, for the most part, know this. They know this. The AMA knows this. The National Pharmacy Association knows this. This is well known. You can ask for an increase. They'll look at you and maybe they themselves at a local pharmacy won't have heard it, but you can, I will put together, the California Pharmacy has a newsletter that's gone out, and it's perfect. It describes what the thresholds are and what the pharmacist is supposed to do. And I'll make sure that you get those. Okay. And if they don't follow up, you should put in a formal complaint with your pharmacy. Shell, I'm going to give you more time next time, sweetie. Can you and I'm sorry to do this too, just a very short, do tell people what you've done with your complaint.
Okay, real quick, until next week, a year and a half of work, hard work, back and forth. And if I can do it, anybody can do it, because I don't have a computer or a printer. I had to go to a UPS store a lot of times. And thanks to that, can I tell who helped me or not?
You sure can.
My very, very good friend, and I love him, Red Lawhern, helped me and really gave me a lot of encouragement, and I owe him a big stake. And after a year and a half, I showed Pat Irving screenshots of all my documents I would get from the California board, and all of a sudden I get another one, and they said, we want to set up an interview with you on these 2 days. And of course that was like, another hurdle, but you have to be persistent. You have to get, like Pat said, people who answer the telephone, whatever. You want to make them your best friends, trust me. Right, Pat?
You betcha, and you did just that.
Yeah, and of course, then after I had my interview with this man, of course, then all my negative thoughts, Pat knows, nervous Nelly, oh, I should have done this or whatever. But, I did the best I could. And it was regarding my forced tapering and all my medical conditions. And, I just laid it right out. So now he said, to be honest with you, it could be 2 months, 3 months, another wait, but for sure by the end of the year. And I figure, I've gone this long and this hard, and you just have to hang in there. But if I can do it, trust me, you can do it, because right now my weight fluctuates between 83 and 88 pounds. So I have no energy at all. So,
And I hate to cut you off. Thank you so much. And I'm going to give you much more time at an upcoming one where there can be questions. And you've done a very brave thing to go through what you did when you didn't feel good. And I am very hopeful for positive outcomes. So thank you, Shell, for what you've done. It's really appreciated. Go ahead.
thank you.
You're welcome, Shell. Goals for next meetings. We talked about it already. I'll be short. Evaluate your guidelines. Use that checklist. Are they good, bad, or ugly? Listen in to your state board. Do it live if you can, but listen to a replay if not. I am taking notes, and next time I will give you more information about who's in what state and what strategies we can use to go forward. Thank you, everyone, so much for participating. I honestly believe we are making a difference, and we're going to make changes. So thank you so, so much.
Thank you so very much. I have an announcement. It's quite important. This is from Dr. Harbut, and it is a new tool for patients and doctors, introducing the NanoLoom Pain Tracker and Diary. It's an easy-to-use tool designed to help you document and track your pain. Why was this tool developed? Chronic pain can be overwhelming and difficult to describe. You may forget important details or struggle to explain how you feel. The NanoLoom Pain Tracker and Diary simplifies the process, allowing you to track your pain anytime. By recording the intensity, location, and spread of different types of pain, you can show your doctor exactly what you're experiencing and how treatments are working. Now we have some key features. One is to track multiple pain types. As Dr. Tennant has taught us, the ascending, descending, and neuropathic pain. This monitors up to 16 types of chronic pain with the option to customize 3 types based on your needs. This option helps you precisely communicate what you are feeling. Number 2, pain intensity. Record the intensity of each pain type on a 0 to 10 scale, providing your doctor with valuable insights on how each type changes over time or in response to treatment. Number 3, pain location. Use an intuitive visual model to map the location of each pain type. The app allows you to layer or outline multiple pain types in the same area for a comprehensive view. Number 4, pain coverage. Track how the spread of each pain type responds to medications and treatments. This has been developed with expertise. The Pain Tracker and Diary was created in collaboration with healthcare and software professionals to ensure it meets the needs of chronic pain patients. Why the NanoLoom app matters. Our goal is to provide a simple, effective way for patients to track and communicate their pain. The app generates a detailed map of your symptoms, helping doctors see and better understand what you're experiencing. The detailed information can help lead to more accurate diagnoses, optimized treatment plans, and better progress monitoring. Looking ahead, at NanoLoom, we believe that the Pain Tracker and Diary can revolutionize chronic pain management by understanding each patient's pain history. Accurate recording and visually sharing your pain data can help your healthcare providers create a more personalized treatment plan. The NanoLoom Pain Tracker and Diary can help bridge the gap between patients and doctors by improving communication and ultimately enhancing treatment outcomes and quality of life. To get started and for more information, you go to nanolume.com. That's NANOLUME.com. And you can download the app on the App or the Google Play Store. And for support, and you can email support@nanolume.com. Thank you all for listening.
Thank you, Jamie.
You're welcome.
Thank you.
I hope that helps you. Huge
Thank
thanks,
you.
Pat. Huge
Jamie.
thanks to Dr. Tennant. Huge thanks.
Yes,
Thank you,
great
Dr.
news
Tennant.
from Dr.
Thank
Tennant.
you, Dr.
Thank you,
Tennant.
Dr.
Thank you,
Tennant.
doctor.
Thank you.
And thank you to each
Pat.
of you who
Thank
stuck
you.
around. You did not give up. Thank you. Thank you. Thank you.
You
We'll
do
get
a
through this.
wonderful job, Jamie. A
Yes.
wonderful
You
job.
do.
Always.
And we
Thank
love
you.
you.
We love you too. This
Thank
all the love,
both
all the
you.
love in the world is for you all. Thank you
Thank
so
you,
much.
Thank
Pat.
you.
You're
I
welcome.
love all
Thank
you
you,
guys.
everyone.
Love you.
Good night.
Good
Good
night.
night.
See you next
Good
week.
night.
Night.
Good night,
Love
Dr.
always.
Okay, great job. Okay.
Kindness
Good night,
matters.
Jim.
Kindness
See you in a week.
matters.
You did such
All
an
right,
Night,
excellent
y'all.
Dr.
job,
Tennant. Hi,
Pat.
Dr. Giss.
Love you, Jamie
Thank you.
Sanchez.
I
Love you,
love
Dr.
you
Night,
too,
Pat.
Brando.
Night,
Thank you so much,
Brandon.
Pat.
You made me
Thank you,
smile.
Pat.
I love
Brandon,
you
thank
all.
you. Thank you.
You're welcome.
Pat,
I'll
you
talk
did
to
an
you
Good night,
soon.
everyone.
Talk to you soon.
Good
Good
You
night.
night.
rocked it. You
Nice
rocked it,
seeing y'all.
girlfriend. You did
God
it.
save
You did great, Pat.
warriors.
Thank you,
So
Pat.
proud of you, Pat. You did such
Thank
an
you.
excellent job.
We did it. I'm
Teamwork.
glad Shel was there too. All right. We'll talk soon, everybody.
I gotta
Bye-bye.
learn
Good
computer
night.
stuff.
Love you guys.
Love you too.
Love you.
Thank you all.
I love you, Jane.
You too, buddy.